We'll be talking about dizziness. This is a review. We've done reviews before and we'll keep on doing them. This is probably the most serious symptom you're going to come across, this and headache. So we're going to keep doing this until I'm happy that everybody's on board with this. Don't take this lightly. So this will be a review though. And if this is anything more than a review for you, go back to previous videos and your notes and check this out because it's really quite important. So to define the term, it's a sense of disequilibrium or disorientation. I think this is the best definition I've seen of this. As I say, it's an extremely vague term. So mostly when you look at different texts online, they'll simply give you a list of possible symptoms that may be there. But I think as a concise statement, this is what it is. It's not particularly an operational definition, but the best definitions are often not operational. And we will look at the different descriptors of each type of dizziness we're talking about. But as a general term, a sense of disorientation or disequilibrium works absolutely fine. There is an exception to this with type 3 dizziness, and we'll talk about that when we get to it. But otherwise, this works for us. It's not your job to tell a patient they're not dizzy if they don't fit into this definition or into a list of possible types of dizziness. If the patient says they're dizzy. Your job is to find out exactly what it's telling you, not say, no, it's not. Most textbooks will give or categorize dizziness as etiology-based and symptom-based, and that's fine, except this has to be given to you, has to be handed to you. So if you're the first person who's actually assessed this patient dizziness, or you're the first one they've complained to, or you've done something that's caused that dizziness, then this is no use to you because it is etiology-based. But that's usually the way it is, central or peripheral. The other categorization more useful for us is symptom-based classifications, which you're going to get from the patient and then work your way through these to come up with an etiology as best you can in the confines of your clinic. So 3 types of dizziness: type 1, type 2, type 3. Type 1 dizziness is an illusion of movement. Either you feel like you're spinning or the room's spinning or swaying or some other movement is going on. If the feeling is you're spinning, then it's subjective vertigo. If the environment is spinning, then it's objective vertigo. And it used to be believed that one of these was more indicative central and the other one's more indicative peripheral, but I don't think that's believed any further. So we have vertigo, which is an illusion of spinning movements, most commonly through a vertical axis when you're upright, or if you're laying on your back or your stomach, a coronal axis, so you're spinning around your length rather than around your the length of you is spinning rather than the narrowness of you is spinning, if you like. The one is your feet going round when it's coronal, and the other one is your head going round when it's vertiginous, when it's vertical. The other type of illusion is oscillopsia, which is an illusion of swaying, but it includes more than that. It includes bobbing, jerking, a swaying movement from side to side, forwards and backwards, or they can be linear movements, but it's a movement that isn't a spinning movement. I had a patient once tell me that they know there was a problem because they was back in their 4x4 along a bit of a rough track, and when they looked in the mirror, it looked smooth, so they knew they was in trouble from that point on. It happened to coincide with the runs, which is quite amazing, but they're the 2 types. Now, both can be central and both can be peripheral. We'll talk about deciding on vertigo, whether it's central or peripheral, from the way you can get history from them. But oscillopsia is such an unusual type of dizziness, one that you're rarely going to come across. My suggestion is that you don't necessarily treat it as a central condition, but you don't mess with it. Have somebody give you a second opinion, as a vestibular therapist or an MD. If you believe that there is an urgent central problem going on, then get it to the ER. But I wouldn't mess about trying to distinguish which it is, because you're really not, as a manual therapist, qualified to do this. So get an expert, more expert person to give you that opinion. Vertigo, on the other hand, is actually not an uncommon symptom. And these may well come into your clinic either with a history of vertigo or with the vertigo, or you may do something to them that gives them vertigo. And these ones you have to try and work your way through. So I would leave oscillopsia alone, give it to somebody else. And vertigo, you can go forward with it. So you can get, if you are going to send us out for a second opinion, you can either send it to an MD or you can send it to the ER or a vestibular therapist, along with the information you have from this patient. Type 2 dizziness is also called presyncope dizziness because it's a feeling you may get just before you faint. This includes, and actually the terminology used here actually depends on the culture doing it. There are different terms that are used in, say, Britain versus the US or Canada. And this is just a language issue between them. There's no real significance in which one you use. It's just your culture. So there are terms that will be used in Britain that wouldn't be that obvious to an American, for example. Anyway, it includes lightheadedness, wooziness, giddiness, faintness, like you feel like you're going to faint, nausea, blurred sort of a feeling, not vision now, but a blurred sort of feeling. You're just not with it. And this is mostly about disorientation now, whereas vertigo and oscillopsia is about movement. And again, this can be caused by central problems or peripheral problems. So you can get this from basically a stroke. You can get it from eating too much chocolate or not eating enough chocolate, for example. Medication does this. Cervical spine problems will more commonly cause this type of dizziness, although, interestingly enough, they can cause vertigo as well. But this is more the feeling of disorientation than of balance loss. So type 3 dizziness actually isn't dizziness at all if we're saying it's a sense of disequilibrium. This is actually disequilibrium, so that you're having trouble finding your balance point and you're staggering a bit. Now, this will happen to you with peripheral or central stuff. And I'll give you an example. When you were a kid, you basically made yourself dizzy. You span around and around and around. We all did this. And the first thing you get is vertigo. You get this feeling that everything's moving around, everything's spinning around you. And you can't find your balance points. You're staggering. You're going from place to place and you often fall over. When that passes, you're then left with the feeling of, why in God's name did I do that to myself? Because now I'm going to throw up. So you've gone from type 1 dizziness plus type 3 dizziness into type 2 dizziness. So you've had all three types of dizziness just by making yourself vertiginous. Disequilibrium without vertigo, though, and disequilibrium with type 2 dizziness really does strongly suggest a central neurological process going on, and you don't want to mess with this. This is ataxia does this, but this is not something that you want to be playing with. Okay. So central versus peripheral vertigo, type 1 dizziness. As I say, if this is oscillopsia, I wouldn't mess with this much at all. Just find somebody who can help you out with it. But if it's vertigo, central vertigo tends to be mild to moderate, whereas peripheral vertigo is almost always severe. And basically, you're either going to sit down or you're going to fall down. Central vertigo tends to be persistent. It'll go on after the trigger has basically been removed, whereas peripheral vertigo is non-persistent and will generally go away within about 40 seconds. However, there are exceptions to this. I remember I was seeing a ballet dancer, and she had neck problems, and she was talking to me about, she was getting really severe vertigo as well with this. And when I asked her about it, she had 2 attacks, basically. The first attack was, she was rehearsing something, I don't know, whatever ballet dancers do. Anyway, her partner lifted her overhead in the small of her back, above his head that way. So she was draped backwards and like basically hyperextended all the way down her spine, just supporting in the small of her back. She got immediate severe vertigo, passed out, and the patient put her down on the floor. You had to lower her down very carefully. Anyway, she went to see the doctor. This, and it lasted, actually came round fairly quickly, but the vertigo lasted a couple of hours. So everything there says this is central. She goes to see an ENT who wasn't a neurologist, and basically he said, well, you need to get used to it. So he told her to let her partner lift her overhead again and again and again, so that she would accommodate to this. Anyway, he did, got her up, exactly the same thing happened. She went out like a light, he lowered her down, and took her a couple of hours to get over the vertigo. Well, she'd had enough of that at that point, and I got her in to see a neurologist. And the neurologist got back to me and said, it's actually peripheral. And he said, this is really weird. He said, because everything about it says it's central, but it's actually peripheral vertigo. And essentially, she went from that point on. But this is one of the exceptions to this, and it does happen. But these are the normal way you look at this stuff. You're better off doing what I did, make the mistake on the wrong side of this, and on the right side of this rather, and get seen by somebody else. They make a mistake on the wrong side, assume it's benign, and do something that's not going to be good for them. Okay, so central vertigo can also alternate direction, go in alternative directions. So they can spin clockwise one time. Within the same attack, it can switch and then switch and go the other way. Or between attacks, one attack will be clockwise, the next one will be counterclockwise. Whereas with peripheral vertigo, this tends to be unstable. It's always going to be counterclockwise or clockwise. Central vertigo can occur around a sagittal axis, so they feel like they're somersaulting forwards or somersaulting backwards. I would always assume this is central. This is really quite rare for us, and I would assume this is central, and it usually is, I believe. Certainly, if the patient feels like they're somersaulting backwards, then this is almost certainly going to be a severe problem, something like cerebellopontine tumor or Chiari malformation. It's got to be something that's not very nice at all. So I wouldn't mess with the sagittal axis rotation, and either a really good vestibular therapist or preferably an otoneurologist if you've got access to one. The peripheral vertigo will generally stay around either a vertical axis if they're upright, or if they're laying down, this may occur around the coronary axis. Neurological symptoms are actually quite rare with a lot of these diseases that are producing vertigo. Vertebral artery problems, for example, generally speaking, won't become neurologically symptomatic for a couple of weeks, sometimes even with a full-blown stroke. It's a really strange pathology, because even MRIs are not particularly sensitive to it within the first 24, 48 hours anyway. But if you do have neurological symptoms, that's it, you're done. Don't worry about anything else. Just get it out. And if they're cranial nerve stuff and it's post-trauma, get it to the emergency room. If you're less concerned, get it to the physician, but don't even worry about looking at this, because whatever you find, you're going to do the same thing anyway. Peripheral vertigo should have no neurological signs or symptoms. Now, the exception to that is when you have vertigo, you're often going to get nystagmus with it. And during the attack, they probably will be. So they may complain of blurred vision with this because of the nystagmus or reticulous retinal slip. But that's about it. They're the only neurological symptoms or signs that you want to see with this. And even then, if this hasn't been diagnosed, you know this is a full-blown vestibular problem. I'd fire it out before you start messing with them too much. Spontaneous nystagmus. Nystagmus is present when they're not vertiginous. This isn't a vestibular reflex problem. This is neurological. Don't mess with it. And with peripheral vertigo, they should only get nystagmus when they've actually got the vertigo. Now, we can also look at the hint test, which I'll talk about in a second, and you're looking for alternating nystagmus or a positive skew, whereas with peripheral vertigo, it should only be a single direction nystagmus and no vertical skew. And we'll look at that in a little bit more detail now. HINTS is an acronym, Head, Impulse, Nystagmus Test and Skew Deviation. Basically, you hold the patient's head in your hands that way. They look at the end of your nose and keep looking at it, and you gently but quickly turn the head about 30 or 40 degrees to the right and then to the left. And you look to see if you've got any jerks in the eye. So it's a saccade rather than a nystagmus, but it could produce nystagmus, but it's likely to be a quick corrective catch-up. Now, that's positive for the periphery if this is only occurring to one rotation. And the side that's got the peripheral vestibular dysfunction is the side on the saccades that you're seeing. If the saccades or the nystagmus is centrally generated, it will be present with in both directions occurring. So you turn to the right, they'll get that saccade. You turn to the left, they'll get that saccade again. This is almost what I've got up there is word for word from an article in the National Library of Medicine, and the citation's down there for you to look at. And then you look for skew deviation. So basically, they look at again, you cover up one eye and quickly uncover and cover. And what you're looking for now is the saccades basically going up or down. And any vertical saccade you see is indicative of a central problem. So most you want from this is either a negative, completely negative test, or nystagmus in one rotation only, and the skew deviation being negative. It's very highly sensitive and specific, this test. The sensitivity is between 96 and 100%, specificity between 96 and 98%, and it gives you a positive likelihood ratio of 24.0 and a negative likelihood ratio of 0.4 with the lower range, and it's infinity and 0 in the upper ranges. So basically, this test is going to be very accurate when you come to look at using it for divining whether this is peripheral or central. The problem you got here, the patient must have vertigo at the time you do it. Otherwise, there's no point in trying this on a type 2 dizziness patient or on a patient who is at the time not vertiginous. Looking at central versus peripheral etiology with type 2 dizziness is much, much more difficult. It's not as clear as it is with vertigo. So I think it's reasonable to assume it's central if this persists for more than 15 minutes. So the patient's either telling you it's going on for half an hour or longer, 15 minutes or longer, or you've done something to them, they've got this lightheadedness, wooziness in your clinic, and it's going on and it's not improving. That should probably go to the emergency room. Also, if you couple this with a posterior headache and decouple it from neck pain, assume that you've got something like VBI there, and get the patient out of there. If any nystagmus with type 2 dizziness is neurological, now with vertigo and even oscillopsia, the nystagmus may be because of the vestibular ocular reflex being messed up. Here, there is no problem with the vestibular ocular reflex, there's no illusion of movement, so any nystagmus is neurological. So it means that any blurring of vision with this is also neurological. So pull it out. It may be due to the nystagmus, but the nystagmus is caused by a neurological problem. And any neurological signs and symptoms that are present are obviously going to tell you this. And a positive cranial nerve test will make you get this to the emergency room as well. So if you have a patient with vertigo, make sure that unless the vertigo is going on and on and on, you've got to get them out there. But if this is non-persistent vertigo, it's almost impossible to do a cranial nerve exam while they've got severe vertigo. So what you can do here is wait until the type 2 dizziness starts and then do your cranial nerve exam during that period. So type 3 dizziness, as I say, if the vertigo goes away and they've still got disequilibrium, it's probably neurological. If it exists with type 2 dizziness, it's almost certainly neurological. You can do the toe to knee test, the heel to knee test, finger to nose test. If they're positive, neurological, any neurological signs and symptoms present suggest that this is central as well. All of this will either have you referring back to the MD or to the emergency room, depending on how much of a urgency you think this is. Well, this is one process that you can use for determining where you are as far as this dizzy patient is concerned. So let's go vertically upwards and we'll look at type 1 dizziness first, and we'll look at the patient who's currently vertiginous, okay? So currently vertiginous, yes. Positive, is there a positive cranial nerve exam? Yes, send it to the ER. Again, or the MD, but probably in this case, you probably should send it to the ER. If the cranial nerve exam is negative, you can start thinking about doing the HINTS test. Now, I'm going to say this again, this is a patient who is not traumatic, we're not worried about VBI, there's no coupling with headache, or there is no headache. So we're not worried about VBI here. We can do HINTS because we're not worried about fracture. So if what we're saying is we have bidirectional nystagmus and or a skew. If the answer is yes, again, to the emergency room, that's a pretty damn good test for likelihood ratios. If the answer is no, it's probably peripheral, and we can move up and start thinking about this vertigo as spondylogenic. So what we can do now is stress the neck, and you can do this with wobbling, where you're trying to see if you can relieve the vertigo, or you can do non-movement stress where you're shearing it, trying to produce nociception and so on, where you're trying to make it worse. But either one, if it makes it better or makes it worse, then you've got your link with the neck, and it's probably spondylogenic, and you should be able to relieve it by treating the neck. If messing with the neck doesn't help it, then it's probably hypofunctional, and therefore you want to do these tests or get a vestibular therapist to do these tests for you. If they're not symptomatic at the time, then we need to do a history. Is this mild to moderate? Yes. Is it persistent? Yes, it's probably central. Get a second opinion from an ENT or a vestibular therapist, or send it to the emergency room if you think it's more serious. If it's severe, is it persistent? If the answer is no, it's probably peripheral, and continue with your exam. If the vertigo is persistent, I would take that as being probably central. And I wouldn't mess with this too much. Now, if we move down now and look at type 2 dizziness, are they currently dizzy? Yes, cranial nerve exam. If it's positive, go to the ER. If it's no, is this persistent? Yes, send it to the ER. If it's not persistent, do they have blurred vision or nystagmus? Yes, get it to the ER. If they don't have blurred vision or nystagmus, then you can stress the neck. If it improves, then it's spondylogenic. If it's negative, what you can say is probably not spondylogenic, and you can either ignore it or you can send it to the MD for his opinion or her opinion. Remember, though, that you can ask about etiology, things like what medications they're on, how long has been present, is it likely they've got a concussion, and so on. So I'm putting MD up there for opinion, but you've got stuff you can plug in there yourself as well. So this is one particular process that could be used to investigate the patient with dizziness.